Good afternoon, everyone. It's my honor to be taking part in Singapore Spine Society. I would like to share my screen. Today, we'll be discussing about biportal endoscopic spine surgery, and we'll be discussing in particular decompression. This is my disclosure, and this is my credits to my mentors. They are from South Korea, who I learned both uniportal and biportal endoscopic spine surgery. We'll try to cover the history of endoscopic spine surgery, in particular biportal, and label the differences between biportal and uniportal endoscopy, as well as to highlight the main differences between the BESS and UBE, and discuss the surgery in brief and the literature. Once upon a time, in the 1980s and the early 2000s, endoscopy started out with being mainly in transforaminal area. We will visualize with the endoscope and perform using working channel through the transforaminal area and do discectomy. Subsequently, in the 2000s, it has evolved into interlaminar as well as paraspinal approaches to endoscopy, and spinal stenosis, cervical and thoracic application in the late 2010s. And now we have applied interbody fusion as a fourth generation endoscopy. The challenge in uniportal endoscopy is that we have different degrees, different length, as well as different approaches, as we need to dock and work around the dock area with some exceptions. So each of them have its specific instruments and learning curve. Hence, it is a steep learning curve for users, and which with specific instruments that cannot be used for other types of spine surgery. At the same time, in the 2010, the South Korean neurosurgeon developed UBE, and in 2014, the orthopedic surgeon developed BESS. BESS involved mainly using mainly using osteotomy, and the UBE mainly using drill as well as other spinal instruments. Soliman from the Middle East described the irrigation endoscopic decompression, which is similar to that of the UBE and BESS system, and basically using arthroscope triangulation and spinal instruments and managed to do decompression. Was published in the Spine Journal. It's one of the earlier publications. And the good thing about biportal surgery is that we can use the same position and apply it to all levels of spine, from cervical to lumbar, and perform decompression discectomy as well as fusion that across all levels using pretty much similar position of the left hand with non-dominant hand holding the scope and the dominant hand holding working instrument through a different separate ports. The benefits is less invasiveness, less pain, less bleeding, and irrigation surgery limiting the infection rate, having good panoramic view rather than a more zoom-in view in uniportal surgery, with unlimited working space because of the difference of left hand or non-dominant hand holding the scope and the right hand holding working instrument. This magnified view also at the same time allow easier differentiation of separate tissues and structures, and we can use ordinary spine instrument as you can see here. Normal spine curette as well as nerve hook can be used in the surgery. The benefits to a surgeon is that we also are familiar in our training as an arthroscopic surgeon in orthopedic to in shoulder and knee, and can be extrapolated to spine, do the same triangulation. This upright posture allow us to prevent degenerative condition of our own spine. Ergonomic visualization can be enhanced by the scope and TV size. Yeah, as our vision get poorer over the years, we can have a bigger TV as well as a nicer high definition scope, for example. Can engage our assistant to retract and help out with osteotomy. And we are familiar with the instrument naturally because they are modified spine instrument, and many of them are also ordinary spine instrument can be used. Such strong magnification, high magnification up to 33 times, 0.5 times, allow us to differentiate the favorite tissue plane. However, because of the difference between the visualizing endoscope port as well as the outer working instrument port, if there's a bleeding, it tends to be a little bit more difficult control. However, with good hemostasis techniques as well as experience, once it gets under control, you can see that the visualization improve and we can work better with the instruments. The main differences that I've highlighted is mainly the use of osteotomy or drill, and in terms of BESS and UBE, otherwise pretty similar. In terms of the skin incision, BESS incision mainly in the interlaminar space, or the UBE 1.5 cm away from the spinal laminar junction. I have done on both types of surgery, and I personally find that there's no difference in terms of outcome. It's really your comfort level. So as you can see, the BESS portal on the left side is mainly in the interlaminar space. On the right side, we can do it a little bit lower so that we can resect less bone as we get across the contralateral side from the working port. And this is UBE portal. Again, it is mainly based on spinal laminar junction and measuring 1.5 cm of it. We tend to shift a little bit lower in the right side. And this is a concept that I explain why right side needs to be a bit lower so that as we get the working instrument in, it won't be blocked by the proximal SP base, and we tend to need to resect less instrument if the both of the ports are slightly lower in the interlaminar space. So there's also a difference in the left and right view. I'll go through that in the next time we discuss biportal scope. So in BESS, biportal surgery is triangulation. You can see the instruments come at a different angle as the viewing endoscope. You can also see first before you perform your instruments, and you can use a large osteotome like this to take out the inferior articular process. While in UBE, there's more drilling, and the BESS we use more osteotomy, as you can see from here. So recently there are more academic activities and literature research on UBE, as you can see over the past few years. And the few leading articles shows that it is a good alternative to uniportal as well as that of the minimally invasive tubular surgery. It shows it has a variable mean operative time, preservation of facet joint with a good early post-operative pain relief, and no long-term differences in terms of the three types of surgery, and more importantly, you can preserve the facet angle. So overall, both BESS and microscopic and uniportal in different experienced hands produce good clinical outcome. BESS and uniportal might have a little bit better post-operative pain relief, and it preserves more facet joint as a result of the better visualization of the tissues. Main complications in the learning curve period. There may be more likely causes of complications in the first 20 cases or so, which involve mainly the death of the dura tear, as well as that or sometimes neck pain, echoes of headache, as well as hematoma formation. In my own personal experience, I mainly have only dura tear in my series. However, I've seen a water-based irrigation, neck pain, and headache in my time in Korea. I also heard from Dr. DJ Choi in his early 2010s. The wrong radiofrequency ablation setting can cause effects similar to ECT, can lead to cardiac and CNS issues. So it is important to use the good pressure per mean of 30 to say for cervical, preventing neck pain and headache. And we have to apply the correct electrical radio frequency. Basically, we use the higher radio frequency in orthopedic limb surgery. So currently, after various invention and innovation, the Koreans have come up with a formula of using a high radio frequency energy and a low radio frequency energy. The high energy is used near dorsal to the flavum on the soft tissue at the lamina, while the low energy is used near the dura structures. So as you can see here, if you perform using biportal using the limb arthroscopic energy system, it's like doing ECT to the brain. It can cause patients to wake up stuporous, and it can be quite anxious for the patients and surgeon after surgery because the patient's not responding well in terms of the CNS alertness. So you can see here we use a low energy about 10 to 40 watts rather than that of the high watts used in the system in arthroscopy. So the Korean came out with a system that can typically design for spine, and this is what I use. And the dura tear, this is a paper that we published, my mentor and I, talking about using the tackle seal patch technique to repair various size of dura damages. Of course, we can convert to open as well as dura tear. In biportal, we can also use non-penetrating vascular clips to repair, as well as using sutures using Yuen's technique and the other inlay and onlay technique for dura repair. Basically, just to show this is the setup, we make portals, we create a subfascial working space, sublaminar working space, superficial phlebectomy, laminotomy, resection the SAPIAP, and do a distal laminotomy and distal flavum resection, hemostasis, retract nerve root discectomy. These are very similar to that of microscopic surgery, and my setup is very similar to my mentor's left hand, non-dominant hand scope, and dominant hand holding RF drill or artro. And working instruments, we have the best set available in Singapore, and that we use a waterproof NSK drill as well as a Delphi system, and we can have a SWES dam for water output. So generally, this is what we have in terms of the systems. This is a local case example. We've done it recently. This patient has severe spinal stenosis, claudication distance time is 10 minutes, and feeling numbness after 10 minutes in the buttock, severe stenosis, can't see the spinal cord, and we started out with using the high energy radio frequency ablator, soft tissue dissection, find out where is the spinal laminar junction, perform the proximal laminotomy using the drill, and then we work on the distal laminotomy to create enough working space for the interlaminar window. Once we have created enough working space and lift off the superficial flavum, we can get to the contralateral side. I like to do the contralateral side first before really taking out the ligamental flavum. Once we have done the laminotomy on the contralateral side, then I start taking out the flavum. This is the ipsilateral flavum with the dura exposed, and then you can see the contralateral flavum is removed by using the Kerrison plunger, and you can see that we can look at the contralateral side and do the decompression on the contralateral side as well. So now we're exposing the caudal aspects of the flavum, performing hemostasis, do the decompression, and then finally we can visualize the traversing and exiting nerve roots, mainly the traversing nerve as well as that of the ipsilateral and contralateral side. Finally, resecting the facet joint. We really don't need to resect a lot of facet joint. We just resect enough to see the traversing nerve root. Can get the this patient mainly have the central canal stenosis, so we do enough the flavum resection and release, and in the end she had two small wounds. She's able to walk within a few hours of surgery and discharge the next day. She's currently 1 month out and has no symptoms, no pain, VAS 0 and OTI 0. So in summary, in the expert hands, if whoever or spine surgeon, we are interested in each of these technique, biportal, uniportal, or microscopic tubular surgery, they're minimally invasive surgery in general, as long as we are comfortable with the technique and we apply it in the correct patients with good indications, they produce good outcomes. It's not easy to really compare which technique is better. It's like talking about Taekwondo, Judo, and Tai Chi. Each of them, if you master it well, we master it well, you can perform good techniques and good surgical outcome. Thank you very much.